So this little girl was my patient. She has very high level of spinal cord. She was 2 months old when she was involved in the car accident. So she was C4, which is diaphragm level. She couldn't breathe, so we had to put the trach. But actually, one level she got better. So she didn't need to have this tracheostomy. We were about to close at that time, but she was posing for me to take a picture. So she always move around with this portable ventilator together. So we can close this, even though we make the trach, we always are able to close. So the non-invasive ventilatory care concept came out, and especially Dr. Bach, he came from France in 1980s, and he was really working hard on the cough later. In 1997, the definition started to come out, which is we are giving ventilatory care not through the endotracheal tube, but through the nose and mouth. So you can see, actually, we have a very good model here from Netherlands. I was extremely happy to see her. But look at him. He has kyphoscoliosis. And his lip cage is very narrow, so he cannot really expand his lung. Lung gets smaller. But he doesn't want to put the trach, so we made a nose piece, and he breathes, he talks. And then this young man from Japan, since Dr. Bach brought this concept to Japan, so before he was there, they couldn't do anything, but they put the ventilator. Their tidal volume was 150 to 200 cc only. So when he pushed the maximum insufflation capacity, I don't know if you guys heard the air stacking exercise, which is long range of motion. When he tried to do that with the Ambu-Back, they couldn't tolerate, because the patient was on the ventilator, but the volume, what they were getting, is very small volume. 200 milliliter only. So when he tried to increase the lung volume, they couldn't tolerate. So slowly they were able to go up. So now he is off the ventilator, off the trach, and then he is using the mouthpiece. So while he's talking, he doesn't need to use the mouthpiece. But when he needs breathing, he can use this mouthpiece. This lady is very sad. She has ALS. So 30 months after the ALS, she developed the hypoventilation, which required tracheostomy, and she refused. So she came to Dr. Bach, and then he was able to control this one non-invasively. But 6 months later, her disease progress was very fast enough to require the tracheostomy, because her bulbar muscle was very weak, so she really needed it this time. But she refused, and she chose that she wants to die. So that was her choice at that time. And then I got this one from the actual website. It was difficult, but I got it. So I think this one he talked about like 2 years ago when he came to Pompeii conference. So the most common evaluation errors in current medical practice for neuromuscular disorder is we are treating the oxygenation problem, not the ventilatory problems. So why that happen? We just talk about the physician always try to put the oxygen first, no matter what happened, right? It's lung disorder. Let's give it the oxygen. So that was the problem maker. So the misinterpretation of the symptom, we already learned what kind of symptom we're going to have first, right? We're going to be tired, we're going to have a headache, something stuck in the throat, and then later we're going to have a shortness of breath because we are getting weaker. But the oxygenation problem is, once again, that we're going to have more shortness of breath. So you should be able to differentiate. And inadequate pulmonary function, it was, that's why I think many people like Dr. Bach, but some people hate him. He's very opinionated, and he's very stubborn, too. He always like yelling at me, why are you sending patients to the pulmonary function test? We are not doing that. We are doing all by ourselves, because once we send them to pulmonary function test, what happened? They're sitting quietly, right? And then they have to only do all the tests with the sitting position. Well, the hypoventilation, which is shallow breathing, the problem with the shallow breathing, those people usually start to have a problem at night first, right? So we have to measure this kind of numbers with the lying position, whatever they sleep with, side lying or supine like this. So whenever they come to the clinic, our clinic, we measure two different ways, sitting and lying position. And then also, they don't measure cough flow. Why the neuromuscular disorder patient, why they have trouble with breathing? Mostly, is this pneumonia? No, right? Their problem is more mucus plugging, because muscle is so weak, so they cannot cough it out. So they start to have a breathing problem, and they were thinking they have pneumonia, but actually they have mucus plugging. So if as long as we are using the cough later, we can differentiate, is this from the mucus plugging and pneumonia? So if the patient has a problem with the mucus plugging, you don't need to give oxygen, right? You just take the thick mucus out. So, but the pulmonary function test, when you go there, they don't measure your cough flow meter, how much you can cough. They don't measure that one. So he's really against that plan. And then also monitor sleep. We don't monitor sleep appropriately. And our problem is when we do sleep study, what happened? My husband went to sleep study because he's snoring too much. I cannot sleep. So I sent him to sleep study, and then he came back later. He said, Hae-kyung, I couldn't sleep last night. That's not my bed, not my pillow. Wife is not there. So that's what happened to everybody, right? So whenever we bring them to the hospital, they cannot sleep. So the CO2 level always good. But we are sending the respiratory therapists to their house. And then we are doing tests in their room, in their bed. So we can catch up real hypoventilation easily. So that's the problem. And we are relying on arterial blood gas results too much. But let's say we are puncturing the artery. What happens? Very painful. You're puncturing your artery. It's very painful. So you start to hyperventilate, which means you breathe very fast. You are anxious now. Doctor comes with a big needle and putting the needle to your artery. So you are getting rid of your carbon dioxide. So you don't get the right number of carbon dioxide, which is a problem maker. So you cannot rely on. So we are actually checking the end-tidal CO2. So the treatment, once again, we are more treating this problem with oxygen, which is more dangerous. And also we are trying to do tracheostomy because it's comfortable for the doctors. We provide the airway. And then we keep doing like a little suctioning. That's another problem. We prophylactic tracheostomy we do. That's another interesting one. Is even though you don't need it, doctors say, you're going to need it anyway, so why don't we do that now? Then they never close. They don't know how to close, actually. So our goal for non-invasive ventilatory care is we want to evaluate the patient in regular basis so we can prevent future problems. So this is all prevention. So we are doing this screening or screening test, which is a vital capacity and the tidal CO2 O2 saturation, maximum insufflation capacity, peak of flow, 5 different things every 6 months we are measuring in the clinic. And then we are teaching, because I like her so much, she wants to be independent. If I were patient, I want to be independent. I don't want to sleep with this nurse forever. I don't want nurse to be in my house forever. So I want to be independent. But if we don't teach the patient and patient family, the nurse has to be, healthcare people has to be in the house all the time. So she was asking me why we cannot change the knob, right? Turn the knob, turn off the knob. We teach family all the time, so we want them to stay home. So we are teaching the air-taking exercise, how to manage the ventilator, and then we are educating the patient. So that's very important, and therefore we are improving quality of life. So this is for the patients, or for the physicians actually. So when we started this ventilatory care at night, if your vital capacity less than 50% and then O2 saturation is less than 90, 94% or longer than 1 hour, or you have ventilatory insufficiency symptoms, or you have some desaturation during sleep. Multiple my patients usually during the day they are fine, but if we the CO2 study, and then they usually 60 while they are sleeping. So during the day, they are perfectly fine. So this person sleeps with a lip seal mask, and then this is a portable volume cycle. So we choose a volume cycle ventilator rather than pressure cycle. There's no difference, but we know exactly how much volume we can give it to them. So why we are giving volume? We want to do long range of motion, which brings compliance of the lung. So we want to know exactly how much we are giving at one time to stretch the lung, which is about, we can give 25 or 100 milliliter at once.